Welcome everyone. I'm very excited to partner for this session today as part of the South Carolina HFMA chapter. I am the current program chair, Jamie Bailey. So we have Vine Medical talking as well with Moffitt Cancer Center around some quality review program within revenue cycles. So very excited to offer this content to you today. I know that the quality piece of our revenue cycle is incredibly important, but it's something a lot of times that we learn as we're going through it. So I'm excited to hear some best practice and some things that they've learned while also working with the Moffitt Cancer Center. So we do have Mr. Scott Overholt as well as Rebecca Ash presenting today on this topic. So I will hand it over to them, and thank you all so much again for presenting today. And when we are at the close, after we've opened it up for questions, we can just end the session at that time, okay?
Sounds great. Hello, South Carolina HFMA. I have been to your events before in the past, so I probably know many of you. Of course, it's been a couple of years since we've had much of an opportunity, but it's good to connect with everyone. I'm real super excited today about our program. We're going to hear some really what I would consider cutting edge procedures and best practices from Rebecca there at Moffitt. They have really been on the forefront of development, and we've worked very closely with them to take some of their ideas and commercialize them honestly, and we're excited to hear about it today. We're honored to be able to to host this event today. I wanted to jump in with just a little bit about us at Vine Medical. We today serve 800 hospitals and health systems across the country, including Moffitt and some other bellwether organizations like Advent and the Cleveland Clinic and others that you'll hear about today as I give you a very brief overview of our company. Our solutions are healthcare specific. In other words, we don't do anything outside of hospitals and health systems. So everything is built specifically for the problems that are faced within that market. Highly integrated these days with Cerner, Epic, Meditech, other systems of record, electronic document management systems, etc. We offer a really unique platform, single platform that I'll tell you about. Of course, as you can see on the screen, our stuff is all HITRUST certified. We're very highly rated with KLAS. So welcome you to go out and take a look at our reviews there. Basically, what we bring to the marketplace is a really unique set of being able to capture disparate communication events, whether it's voice, face-to-face, or phone, or fax, which is still so prevalent today, whether paper or electronic, images of web visits to payers' web portals, documents, data, anything that you can think of, we can capture for you. And what makes it unique is that it gets indexed to the patient. So it basically builds a database that allows us to do a lot of automation. Today, we're automating indexing of faxed records. So if you have faxes, whether they're paper or electronic faxes coming in, we can help you eliminate the whole indexing step that is very typically manual. We can also do that with voice calls through, for example, with an Epic client. We can allow you to be able to push a button to associate those files with the patient. And that allows you to be able to improve your management, a lot of which Rebecca will talk about today, and to be able to exchange data automatically through automation with the systems of record and the EHRs. This is really my last slide here, but it just is a visual depiction of what I just mentioned, that we can capture all these disparate communication events to create a database that's indexed by patient that allows you to be able to improve performance, to be able to retrieve, share, evaluate, and automate all these manual processes that we see so much in the front end of revenue cycle, in particular inpatient access there, and then to integrate out to the clients or to the EHRs and other systems of record. this is a slide here before I turn it over to Rebecca that basically shows some of the things that we're talking about today. You'll see here, these are results that our clients have accomplished using Trace. And you'll see here, 90% improvements in quality effectiveness scores, which Rebecca is going to really dive in today. But you'll also see some of the other benefits that Trace brings to the table. A lot of reduced denied claims. In fact, there's a good case study here about Moffitt, where they reduced 50% of their denied claims in the first year. Actually, I heard that reported by them at Becker's, even higher the next year. But you'll see a lot of overturned denials. You'll see even things like improvements in point of service collections, a lot of improvements in workflow, less staff requirements, and things like that that our clients have accomplished. So with that, I'm going to shut up about us. We're thrilled to host this event today and to provide an opportunity for Moffitt to tell us their story. So with that, I'll turn it over to Rebecca. And Rebecca, are you going to share, right?
I am. All right, so
Here we go.
1 second. All right, everybody. See my presentation? Our presentation? Great.
Perfect.
Okay. Thank you. Thank you, Scott, for that introduction. I'm really excited to be here today to share some of our best practices from Moffitt Cancer Center. We've spent the last 5 or 6 years really building and overhauling quality. But before we hop into that, just a little bit about Moffitt. So we are located in Tampa, Florida. We are one of 2 national cancer institutes in the state of Florida, and we are the only comprehensive cancer center in our state. So what that means is the NCI, they have several categories you have to meet to have that designation, which is the gold standard in the industry. And we have met all 3 for cancer prevention, clinical services, and research. So we opened our doors in 1984, and now we're at over 7,000 team members. We have 3 standalone outpatient facilities. We have multiple partnerships, including Advent Health, which Scott also referenced. And we have 1 inpatient surgical hospital with a second one in construction that we are expecting to open in 2023. So I love numbers and the story that data tells. And here are some of our stats so that you can see our success. You can see our total economic output of 2.4 billion. We have over 13,000 employment impact, and 86,000 is about our average base salary. My favorite stat is the one where you can see the number of patients that we are helping. And last year we were able to see over 69,000 individual unique patients, with 23,000 of those being new patients. And our goal in this whole process as we continue to grow is just reaching even more people who are affected by cancer, and how can we help them with this ever-evolving disease. And so that is where I would say that our partnership with Vine comes in. So back in 2015, we implemented Trace, which is a solution offered by Vine, and we did it for process improvement in our financial clearance unit and in our patient appointment center. And since then, we have expanded our use of Trace. So we use it for recording phone calls with our patients. We also use it to work list all incoming correspondence with providers and payers. And that has really helped us with scheduling requests from providers, checking benefits, authorization requests, medical records that we are receiving back. And then recently, Screen Record is a newer feature from Trace that we have started utilizing. And we'll get a little bit later into that in the presentation. Also, we house the majority of our quality reviews that are completed in our revenue cycle. So a little bit about our revenue cycle. We are about 770 team members, and you can see the breakdown of the different departments. All those departments, other than revenue integrity and the support teams, they have had quality instituted. And when we break that down, what that looks like, you can see here the number of employees that are subject to QA in those teams, along with the number of roles that makes up and the scorecards. So adding up all those individuals in the different teams, we come to about 540 team members, which is 70% of our revenue cycle. So at this point, we have 70% of our revenue cycle that is having consistent quality audits. The remaining 30% makes up those leadership roles and those specialty roles. So we consider that to be a mature quality environment. And a little bit about my team, because my team is responsible for overseeing the implementation and sustainment of that quality. I have 7 quality auditors, 5 curriculum development specialists, and 1 revenue cycle coordinator. So if you think about it, I have 7 auditors and 1 coordinator that is helping the quality for 540 team members. That's quite a bit there. However, I'd like to take the rest of the presentation and talk about how we were able to do that. How are we setting up our quality programs, best practices? How are we sustaining that? What is that out product and who are we reporting it to? So starting a quality program, it's a very collaborative process. And I have a timeline here to briefly go over the big milestones and mapping it out. The first thing that we do is we get with the leadership of that area. So we get with typically it's the manager, we get with the manager and we discuss the roles that they want to have quality audit oversight on. And with those different roles, we will talk about what are the main functions, what are the risks. So based on what they're doing, do they have a financial impact? Based on their operations, do they have financial considerations? And how are they affecting our patient experience? So we really come at it from those 3 angles when we're starting to consider a quality program. So I would say after that, we then address what mitigating controls do we have in place for those risks that we have identified. And then we talk with the leadership of that area on navigating the team dynamics and the awareness of the team, knowing that quality is coming into play. And if you had asked me 5 or 6 years ago, I wouldn't have mentioned those last 2. But I think what I have learned is that if we want to have a successful quality program and have it continue, we have to have the buy-in of the leadership of that operational area that we are working with. And how we do that is it's a partnership. So it's a partnership in that we are listening to their input, we are learning about their areas, and then we provide recommendations from a uniformity and a best practice perspective. So part of that entails asking the leadership for a few knowledgeable individuals on that team, and then having my auditors go and shadow to learn those roles. And so as they're shadowing, we're starting to craft an audit template that's going to be used. A couple examples you'll see here off to the right-hand side, I have a template for our collections team. When we're building it, we typically go with Excel and we will list out the attributes that we have deemed to be critical for that team member to be successful in their role. You'll see off to the right-hand side that we have scores that we have assessed for them. That is, again, a partnership with the leadership area. We will propose the attributes based on our shadowing and the weights assigned, but it's really the manager who's going to sign off on it. Now, I will tell you that not all the attributes are always applicable. So if it is not applicable, those points, they just reassess within the scorecard so that it's an equal weight distributed. So we'll craft the audit template. And then after we craft the audit template, the next thing we're going to focus on is building an operational guideline. We call them key performance indicator guidelines. This is critical to the quality program. And the reason why is because it is including all the parameters of that quality program. So we're talking about eligible, who's first place, who is eligible to even be quality reviewed, whether they're a new team member, they're a transfer, they're an established team member that has had a new workflow implemented. We also talk about how that KPI, how that audit is completed, how many is done, when it has to be done by, when it has to be communicated to the team member. We document all that out. So there's a clear expectation between all the invested parties. We also talk about the pass-fail threshold and what happens if we don't pass it. What is the disciplinary track? So again, it's a document that we are crafting based on what we have learned from that team, and we work with leadership to make sure that it meets everybody's needs. I will say in the last year, we have centralized our operational guidelines, that we use a template that is consistent all across revenue cycle. one piece of advice for this, when we were creating the operational guideline, we consulted with HR, because with that disciplinary track, quality is assessed on their performance. So if they're not meeting quality, then human resources is involved at a certain point. So we want to make sure that everything was in alignment with our company policies. And it has really helped us as we have incurred occurrences that have to bring HR in. So we have created our audit template. We have our KPI guideline. I will say some of the team members, they do like to have an additional document called a quality agreement. This is mostly our patient access teams at this point, and here's an example of one. In the past year, when centralizing our guidelines, we have tried to incorporate a lot of this information into one document, that KPI document. But again, it comes back to that partnership and what works best for each of the teams, because we're talking with like a wide variety of operational workflows here. What works best for the teams while not compromising the uniformity and the expectations of our leadership. So after we create all these documents and we get it into play, then we start talking about when are we going to go live with it. When we go live with it, we typically have an implementation period. The implementation period it's typically 60 days to, it's called a ramp up period. We allow 60 days for the team to get acclimated to being quality reviewed, to allow the supervisors to become accustomed to completing those reviews and fitting it into like their daily operations. And then also with the supervisors and the auditors working together to reconcile any variances. And so going into that, the supervisors are the ones who are expected to complete those audits routinely on the team members. So we call them first level reviews. So the supervisors complete the first level reviews. And then our auditors come behind and do a subset. And I'll get into that in just a minute. Typically, we ask the teams, they do about five items. They are quality reviewing each month on a team member. And we ask that they complete them by the end of the month, and to have no later than, I would say, the first week of the following month, they're to be completed and to be communicated to the team members. And we do that so that the team member can incorporate any educational feedback in a timely manner, as well if they wanted to dispute, like they can start the appeal process. Our pass fail threshold is typically at 90% at Moffitt. We do a range of 80 to 90%. The teams really that go with the 80%, it's because they have fewer attributes, or there's been a little bit of a rougher acclimation to quality. So we might start at 80%, but I would say most of their teams start at 90%. Now, one thing I also wanted to point out here is that you'll see off to the side on the right-hand side, I have an example of a quality soft skills scorecard. So in addition to the normal quality review that they would have, our team members that are on the phone calls with our patients, they will be assessed on their soft skills. The soft skills, they don't count for that pass-fail threshold, but we do consider that very important. So we will incorporate that into the feedback that we provide them. Now, when we are first implementing a quality program during that 60-day implementation period, the quality auditors will have a much closer oversight in working with the supervisors. So when the supervisors start in those 60-day period, it is for educational purposes for the team members, but the quality auditor is going to go back and reperform half of what they do. Then they connect, they go over variances, understand why, right? And then they reconcile. After that implementation period of 60 days, we typically go to reperforming just one or two of the audits completed by the supervisors. We'll do that for a few months. And then if there's cohesiveness between the supervisor and the auditors and how things are being interpreted, consistently applied and timely completed, there's several factors that go into this. Then we will start scaling back. So then my auditors will then go to from the 1 to 2 that they were doing of each team member. Then they will perform just a small population. So I know I'm using auditor speak. So example, our patient financial services team, they're a very stable team. And so they have over 100 team members. Every month, The supervisor will perform their audits out of all the eligible team members, and then my auditors will come and just pick 25 individuals that had a quality review done, and they will just perform one on those 25. So we start scaling it back as the quality program matures. And I would say what typically happens at implementation period is about 60 days. And then we have another 2 months where we're reperforming quite a bit. And then the 8 months, so I would say at about a year, typically that's what I have found, at a year, the quality program has matured. It's really leveled out. Everything is good between the auditors, the supervisors, even the team members getting acclimated. And that's where we'll start scaling back to like that 25 count for each of the teams. And so that is one way that we are able to sustain oversight of quality on our revenue cycle. When you think about me just having 7 quality auditors and us doing quality over about 542 members. And something else that is interesting, I think, is that out of the 7 quality auditors that I have, 4 of them were supervisors. So when they made that transition, it was very smooth because they had a strong foundation of how quality was done, and they had the sense of importance for it. So we've talked about how to start a quality program, how we implement it, and how we sustain it. I'd like to talk a little bit on what the end product of that looks like. When we started with this about 6 years ago, quality was very siloed. It was siloed, very informal. There's pockets here and there in revenue cycle that had it. But then as we started onboarding teams, we went with that Excel format that you see on the right-hand side. But we started thinking, okay, how can we make this better? How can we streamline it so that we can report to our leadership all our efforts, like make them visible? How can we show the number of individuals that are having quality reviewed? What's the overall health in terms of that assessment score? And how can we do that efficiently and on a consistent basis? So we were looking at what we already had in place. And I'll show you a couple examples here. Right here, at the time, HIM, our coding teams, they were using an Access database to complete their quality, and they still are. And I'm sorry, this one right here is our HIM coding template. And then the one underneath is FCU. They use a web form. All our other teams now, it was a little bit all over the place. So what we did was we were trying to figure out how can we centralize and make that better. And that's where we started looking at the Trace solution, because Trace is actually a very easy application to navigate, and the vendor is very easy to work with. So we started looking at the quality module within Trace that we were already using to audit the phone calls. And we started working with them to enhance that quality module. So we were able to convert in the past couple of years about 300 team members that had quality reviews completed on Excel and have their quality archived into Trace. And it has been a very successful and low-cost implementation for us. And so a couple of the reasons why is because it's an easy access point. All our teams access one solution. We train on one solution for all those teams. Also, it allows us version and formula control. As you saw in the Excel template, we didn't lock down the templates because the teams asked us not to in case they want to make any edits, but sometimes that ended up corrupting the formulas. So with Trace, now we're able to track that version control. If we have to revise a scorecard, we're able to make sure there's no formula hiccups there. And then also it helped promote uniformity and consistency in how our quality reviews, the end results we're looking. So here is an example of a quality scorecard that has been completed and saved to PDF. And this is how we communicate it to the team members. If I go back a couple slides, you'll see in the bottom left, that is an example of a scorecard that we had with the soft attributes. So the team members who are on recorded calls, we assess them on their normal quality attributes, and then also the soft skills. So as you can see between the two, they're similar in their layout, but it does allow us the flexibility if we need to have different attributes and have a slightly different layout. Another beautiful thing about centralizing our quality and trace was that it allowed us to expand our reporting capability. And that was one of the reasons that we started with this. One thing though, before I hop on to the reporting, I wanted to talk about a newer feature that we started using in Trace about 1.5 years ago. Is called Screen Record. And this has been another very beneficial tool for us in empowering our team members with best practices and as well efficiency in completing our quality audits. So Screen Record is a way that if our users, if they're being auto recorded through Trace, we can purchase a screen record license for them and watch their navigation while they're on the phone with the patient. And so we use this, so far we use it in our business office customer service. We use it for our financial clearance unit intake teams, our new patient appointment center, and our patient contact communication center. And it's really helped us in being able to assess trends among the teams, provide those new hires that educational feedback, and be more efficient in how we complete our audits. And especially with the COVID environment and with a lot of our teams being remote now, the screen record, we don't have to sit there and visually shadow or observe them in their interactions. So it's just been very good for us overall. Now, as I was talking about the reporting capability, how it has been so useful for us is that because we centralize down to those 3 quality platforms that we use, the web platform, the Access database, and the Trace application, we were able to build queries and Spotfire to extract those results out to Excel. And we have a business analyst that takes the information from those 3 platforms and builds a quality dashboard. So she uses a template and she plugs the numbers in. So you can see here off to the right-hand side, the results of our quality dashboard. Everything funnels up like, so this is probably what our VP and our senior director, they look at, and they love it because it's just one place where they can see the overall assessment of our revenue cycle very easily. And you can even drill down based to the supervisor level. So when we export things out, we can drill down to the supervisor level to see what's the individual scores for those teams if something was concerning. A couple other things that we were asked by our leadership was if we could include the turnover rate and the tenure of our team members. Also on the top right, you'll see the percentages of the teams that have their quality completed. And there's that 30% that's excluded because it's leadership roles or specialty. So really just a great way for us to streamline pulling the data out for the quality and visualize to our revenue cycle leadership what, like all the efforts and what's going into it. Now, we do report to our internal leadership through this dashboard, but we also have to report to external parties, such as our internal audit and board of directors on our efforts for quality, believe it or not. So I know sometimes we think, oh, it's just a quality review, but that actually funnels up all the way to our board of directors, believe it or not. And that is because quality is considered a key control by our internal audit department and assessing the overall control environment for our revenue cycle. So what that means is, in addition to those monthly audits that the supervisors do, we reperform a subset of, we also have to, on a quarterly basis, pull a random sample and provide to our internal audit support evidence that quality reviews are being consistently performed on the teams in accordance with that operational guideline that we created, which is why it is so critical that that guideline is detailed out, is consistent, and up to date. So we provide those results in Excel, and then internal audit takes and they put them within a packet and they report it to our audit committee, which then goes to our board of directors. So if there are deficiencies that are noted, they are going to know about it all the way from the bottom to the top. That helps us though, because that tone at the top then comes back down. And that's really helpful in reinforcing the importance of quality for everybody. And how we do that, even down to the team member level, is that we include it in our training. So even when a new hire joins our orientation or they transfer in, they take a new hire revenue cycle orientation, as well as a team new hire module. And those training modules, they include components on a section on quality and productivity. So something I didn't touch very much on was productivity, but for Moffitt, quality and productivity, they're viewed in tandem. So our disciplinary track is combined, because sometimes we did notice that quality might be very high, but quality is very high, but productivity very low, or vice versa. So we do look at it at both. Now, I'd like to also mention the other 5 team members that I have on my team, the trainers. We call them curriculum development specialists. What we found was that when we started with quality, we had such good feedback. We were noticing all these trends, all these educational opportunities. So we started including some FTEs from training. So our CDSs, we call them CDS, curriculum development specialists, they're the ones who created this new hire orientation and all the training modules for our teams in revenue cycle. And that is how we are able to incorporate productivity and quality in there. It's a really good relation between the auditors and the CDS, because the auditors have the workflow knowledge and from the shadowing and setting everything up, and also navigating those teams. And then the CDS have the skill set to develop. So the CDSs will also shadow, but using both those roles has really served us well in being able to empower our team members to know the expectations from them from a quality and productivity perspective. And so also, I would say with having those CDS and quality auditors, when COVID hit, I wanted to make sure to mention this. When COVID hit, I'm often asked, like, how did that affect how you do your quality over all of revenue cycle, like all the different teams? Because before COVID hit, we were all on site. And after COVID, I would say 80% of our workforce is either 100% remote, or we have a hybrid where they might come in 1 or 2 days and then the rest are remote. So we really had to assess our workflows. So from a quality perspective, believe it or not, there was minimal impact, I would say, in how we completed our quality reviews. One of the things that we did do is we worked with Trace to have more licenses so that we can listen to our team members that were working from home. We leveraged screen record so they could watch screen navigation, because there was no more, let me just sit beside you and shadow you. I mean, we also use Zoom. So a myriad of those resources, we really, we leveraged those, and our existing platform was very suitable for us going remote. So we had very little impact in how we continue to do our quality reviews. But I think that comes back to how we started off. Like, we started off with, it's a partnership between us and the operational users. We weren't out to get them. We were very transparent in what we were doing. And I think just having that transparency and always having the team members' best interest, that will get you very, very, very far. Okay. And just providing those training opportunities when they arise. So it's a whole picture. Now, I've probably gone over my time, where I'm very close to it. So I'm going to stop sharing and hand it back to Sharon for any questions.
It helps if I take it off mute. Does anyone have any questions in the group? Well, we do have a couple. What applications has your quality system made a big difference, Rebecca?
Quality, I think quality is like, it's like the big picture. Okay. So for us, Sorian is our revenue management system. It plays a very big part in that, because that's how a lot of our quality reviews are completed. We will dive into Sorian in the patient accounts, and we can assess based on the attributes listed in the scorecard if it is met. So when we're doing that, we're also mapping out our audit trail, whether we have to create a reporting off of that, or can we leverage off something the system has already had. So I would say, honestly, I can't think of a system that it hasn't impacted, but we use Sorian very heavily. So I would say Sorian, also with Trace, and being able to dive in. I mean, when in using screen record, if we have a patient complaint, we just pull up that call, we just dive in, and we look to see like the screen navigation while listening to it. It really paints a good picture so that we can provide feedback or get back with the patient. So.
Another question is, how do you decide on the weight for each quality check?
Very good question. Okay. So as we're sitting with them, we look at those three categories. We look to see the financial impact, the compliance, if there's any compliance considerations, and those patient experience. And then we will then say, okay, which one, if you did not do it, would basically break the system, okay? And then we just triage them with that high, medium, and low risk. Now, there are some that make their way in there that we didn't initially assess, but the manager comes back and says, I'd like you to do this versus that. I will tell you also, we do play with it a little bit because we don't want to set everybody up for failure. So we'll look and say, okay, if you fail this, you would fail your quality. So do you really want your team members to fail quality if you fail this one attribute? And if they're adamant and say yes, because it's going to have this significant impact, we then go with that route. So it's really just understanding their workflows and what breaks the system if they don't do it right.
Awesome. How long does it usually take for the program to be standard and accepted?
That's a good question. It takes us about 2 months to pull it together from the moment we kick off to getting that go live date. And the 2 months is needed. Sometimes it can take longer if we have difficulties in bandwidth and getting the operational owners to work with us. But I say for the most part, it's really 2 months to pull everything together. And one thing I did not mention is we a lot of times will create a narrative off of our shadowing. So we will draft out in a workflow the main roles that the team. So if we think about, let me take collections for an example. We will draft a narrative from the moment a claim enters that collections department to everything that they do to the moment it leaves. So we use 2 months to really understand the workflows. We also create a Visio sometimes if they want it. And then we take 2 months to implement. So now we're at 4 months, okay? And then I would say it normally takes a year for us to work out interpretation of the attributes to make sure everybody's on the same page, acceptance of the attributes. But sometimes we'll put it into play and we'll realize, oh, you know what, that's really not working because the attribute's almost always not applicable, or we didn't consider this and we need to go back. So it takes about a year for us to really stabilize it out and have everybody be cohesive and accepting of the quality program.
How frequently are the weights reevaluated?
Believe it or not that often. I think it's because of the due diligence that's put up front. We very rarely reassess the weights afterwards. And that also has to go into, we play with them beforehand. So what we'll do a lot of times when we create that quality audit template, my team, before we even start the implementation period, we'll pick a sample. We'll just go and do random accounts and we'll start like trying to vet out the scorecard. Basically, I'm trying to break it, okay, before I put it out there. So we'll go and we'll start playing with it and we'll come back and say, okay, we did this and we found that like, out of the 25 we looked at, 20 of them failed because of this. Do we really want it to be like this? So I think it's just working it out. And by the time we implement it, I would say the weights are very rarely assessed. It's more that we might tweak the wording of an attribute just for clarity for everybody.
Thanks. How do you QA your remote staff?
Our remote staff? Good question. So as I mentioned in the presentation, a lot of what we had in place, it was able to carry over for our remote staff. So if we think about it, our scorecards, we're already diving into systems. We're already diving into systems that has timestamps, has usernames associated with it, and has an audit trail of some sort. And we had reporting already set up. So we were able to leverage a lot of that. And then we added on the number of individuals that we put on Trace auto record. So I would say that before we probably had more individuals on demand where you could pause a call if you wanted. When they went remote, we converted everybody over to auto record. And then we also started really using screen record. And then, we use Zoom. So after that feedback, so the supervisors, rather than meeting in person with those team members, they would meet with them Zoom, and they had already emailed the scorecard to the team members so that they could sit and they could walk through and provide that education back to them.
how do you notify the patients they're being recorded?
Good question. We have like a phone message that if it's an outbound call, I think it's actually both outbound and inbound at this point that we have a message. We used to verbally say it, but now we just incorporated it because our teams are remote for the most part.
How does the system know to record your screens?
When they pick up the phone call, it automatically starts recording. Something I do want to put in there that we made sure to cover with Vine when we went this route, we do have some of our team members that take patients' credit card information, and that is a big no-no to record that credit card information during the phone call. So even though our team members were on auto record, they can go up. There's a link that Vine provided us. There's a link that we go up and we just hit the pause button and you pause it while you take that credit card information. And then the call resumes. And screen record in the call being recorded, they're in sync. So you just hit, it's the same. Like you don't have to do something different for each of them.
Scott, do you or anyone else have any other questions?
I don't, but great job, Rebecca. It's exciting the work that you guys have done and the leadership that you're providing to the community. So thank you for that. But no, I have no additional questions. And I don't see any that have come in from chat. So I think we're good.
Well, thank you guys so much. I appreciate it. If you have any other questions, please get in touch with me and have a great day. Thank you.
Thank you.
Thank you.